For the next and last concluding session, I would like to invite Dr. Ajay Yadav, sir, Associate Professor, Department of Medical Oncology, Mahatma Gandhi Hospital, and Dr. Puneet Dhar, sir, will join on the chair soon. Thank you.
Good afternoon, all of you. So this is the last session. Before calling the speaker, I would request VK Kapoor sir to allow Dr. Ajay Sharma to sit with me to give me company. So first speaker for this session is Dr. Mahesh Goel, and he will talk about biology of incidental GBC.
Thank you, Dr. Kapoor. When Dr. Kapoor told me to speak on this, I was wondering whether it's a philosophical question or is it a question for debate actually. So we'll see. I'm still not sure what we'll actually be talking about. So all the available literature, what we have discussed here, does suggest that probably it's a different disease because of course, incidence is increasing, but I guess that is because in last a decade or 2 decades, more and more lab collies are being done for various indication, which has caused a jump in incidence of incidental gallbladder by 0.8 to 1%. Of course, younger patients, but then younger patients are the patients who get more operated for for mild symptoms, asymptomatic gallbladder, younger males especially, and improved survival probably we'll see. So these are the studies which gets published which make us think probably that incidental gallbladder is a disease with different biology. This study just published in 2022 looked at 261 patients of gallbladder, but here what is important is to see is that they have clearly written that non-incidental gallbladder cancer patients have more advanced stage and requires more extensive resection. For me, this only tells us that it's the advanced stage. They are comparing incidental to an advanced stage disease and then trying to say that their outcome is better, their survival is better. I don't think so. It really matches up to stage. And that's what they have concluded, that confers a survival advantage. Similarly, this is again published from an extrahepatic consortium from United States, 10 institutes. They again compared incidental gallbladder with non-incidental gallbladder for overall survival. But they again also in this study, they have shown that non-incidental gallbladder cancer patients have more likely to have R2 resections, advanced stage, high-grade tumors, lymphovascular invasion, and positive lymph node. And once you have all these things, and then you say that non-GBC, IGBC are associated with worse median survival, I think it's a no-brainer. They are likely to have overall worse survival with reduced overall survival. And that's what they said, that this underscores the importance of timing of diagnosis. We'll come to timing of diagnosis of GBC, that these two groups may represent a distinct biology of disease. So these are the evidence which tells us, or which probably are trying to point to the fact that incidental gallbladder cancer is probably a disease with different biology. I have a little different view. I think till now there is no clear evidence of incidental gallbladder cancer being a biologically different tumor. It has not been explained on the basis of any genetic studies, mutations, or even environmental or dietary factors. Little bit probably on inflammatory pathway. Yes, all IGBCs are gallbladder which are operated early, and in all probability because of various factors which led to inflammation, and these are the group of patients which follow the inflammatory pathway to carcinogenesis. And of course, carcinogenesis, inflammation does confer a little bit of protection in terms of metastasis in oncology, we all know. So probably in that sense, it may be slightly better in non-metastasizing. But for me, is it really a different biological disease? This is our Tata logo, which is printed on all our buses of Tata. Cancer is curable if detected early. So for us, I think it is a disease which is detected at a very early stage and treated at a very early stage. And that is what gives advantage of survival and recurrence-free survival or overall survival to these group of patients. So again, coming to truly incidental, which we have already discussed, truly incidental are tumors probably which are in situ tumors and T1. T2 would be very rarely truly incidental. If you have to really ask me, they will be picked up on scanning, definitely muscular invasion, or will be visible. So with advanced imaging in today's era, very few T2 would be truly incidental. And so when we talk about in situ and T1 tumors, we know that simple cholecystectomy alone is curative in with 5-year survival of more than 90%. So if we are talking about incidental carcinoma and we are talking about in situ and T1 disease, we know they are curative with simple cholecystectomy only. So there's no question about comparing them to anything else. So question is only about T2 tumors. T3 definitely is not incidental. So if we have T2 tumors, are they really incident? Let's see if from our center we did a study comparing the outcomes of T2 tumors. It was a retrospective analysis which were operated as incidental versus those we operated upfront as radical cholecystectomy. Out of close to 1500 patients, 425 patients had PT2 on final histopathology examination, and 72% were incidental group and 27% were upfront gallbladder surgery. And we realized that patients of IGBC had significant higher local regional disease, local regional recurrence, liver recurrence in the liver, distant liver recurrence, as well as abdominal wall recurrence compared to patients who got operated upfront for T2 stage. And this also reflected in the survival curves, both disease-free survival and overall survival. So definitely the PT2 patients who got operated upfront with radical surgery had a much better survival outcome as against patients who presented with simple cholecystectomy down outside, had PT2 disease, and then had to undergo the whole process of revision cholecystectomy staging, as including the delay in time period. So this has just got accepted for publication in Journal of Surgical Oncology. So next, similar results published in HPB 2018 from Wathi Group and Eduardo Vega. They also looked at surgery for outcomes for incidental versus non-incidental gallbladder cancer, where index cholecystectomy was done and versus patients who underwent oncological resection. And they also showed that the patients who went upfront surgery for T2 resection had much better survival compared to patients who were operated as incidental and had to undergo revision cholecystectomy. And as the time period prolonged, so T2 patient that did much worse compared to even T2A. T2B did much worse actually. So this underlines the fact that probably the patient of T2 who got operated upfront had a complete curative surgery at one go, and we are interfering that process of treatment by doing a simple cholecystectomy. Then the time period, the wait period comes in, which probably results in change in dynamics and increase in metastatic potential. So we had our very early paper on PET-CT in incidental gallbladder cancer, where we looked whether we realized that it does upstage incidental gallbladder cancer, but patients who had localized disease which was picked up after index surgery of incidental gallbladder cancer had 20% patient had metastatic disease or exploration. This also underlines the fact that they should still undergo staging laparoscopy, but all of those patients who had metastatic disease were PT2. So this is the largest paper series which we have published on revision surgery. We are looking at our philosophy and challenge of ideal timing and real world applicability for revision surgery. What we realize that, and I feel personally, is that revision surgery is the best staging modality which we have actually. We don't do much once we have removed the gallbladder. Then revision surgery actually stages the gallbladder disease at that point of time most accurately, with as far as doing frozen section for para-aortic node to look for metastatic disease, peritoneal surface, as well as the number of nodes involvement, especially now that we know the end staging is changed to the number of nodes which are involved. And it is the initiation of the systemic therapy in this group of patients which does most of the differences. And the time to revision surgery does not affect survival. Actually, what we found that as the time period extended to between 10 to 14 minutes, that was the only period which conferred survival advantage. So which again tells me that by waiting little bit more, probably we are selecting these tumors better. And that is what is causing the change in perspective. So it's just a perspective which we have to see whether the glass is half full or half empty. IGBC as a different biology appears a very theoretically attractive concept, better disease, less aggressive tumor, better outcomes. But if we look at it very closely, we will find that it's the same disease which is detected early at a very early stage. It's basically early disease which is being treated. But having said that, if we really go more deep into most of the patients who present to us and whom we do revision cholecystectomy are the patients who remain stable after simple cholecystectomy. But there are a group of patients, almost 30 to 40 patients who would have undergone just a lap cholecystectomy and they present to you in a frank metastatic stage. So these are the patients who had poor tumor biology, but these patients will never be labeled as IGBC ever. They will be straight away labeled as metastatic disease. So this negates the theory of tumor biology theory that it's a biologically different tumor. Also, IGBC allows test of time and biology of patient who gets revision surgery are the patients who are actually super selected for disease, for management, and these are the patients where the disease has remained quiet over a period of time. So they are probably biologically better tumor who got selected to be treated. But we should not forget there is a group of patients who would present after simple cholecystectomy straight away as a metastatic disease. So can we prove or disprove this theory? We cannot disprove or prove this theory by environmental study, dietary modification, all those things. Scientifically, we can only prove or disprove it through by genetic studies, which can profile patients of IGBC and patients of advanced disease, and of course, with a probably a propensity match study of radical versus revision for T1 and T2 disease. So genetically, some work has been done. We published a study in Lancet. We looked at two different gene regions which are strongly associated with risk of gallbladder cancer. So finally, I would say there's still no denying the fact that incidental gallbladder cancer is a distinct clinical entity as of now, which needs to be defined more accurately and treatment pathways laid out clearly so that we can achieve uniformity in management of these group of tumors. And only then we can really look at outcomes to infer that this is a biologically different tumor, and for that we'll need that concept to be scientifically validated. Thank you.
So, thank you, sir, for the nice presentation. I have a question regarding PET-CT. So immediate after surgery, there are chances of false positivity. So when you advise for PET-CT, and what are the chances of false positivity in your experience?
So we do not advise PET-CT immediately after surgery. If a patient present to us immediately after surgery, then for staging, CT scan, chest, abdo, pelvis is the standard of care. PET is only advised 3 to 4 weeks after the primary surgery when the inflammation and chances of false positivity decreases.
Thank you, sir.
Mahesh, I intentionally kept this topic because again, it's a hunch. It's in my mind, but as you said that it will have to be proved. See, if it is this stone which is causing cancer, in patients who present to us with cancer, clinically or radiologically, probably the disease is growing fast and manifests. On the other hand, although we don't know in patients with incidental gallbladder cancer for how many months or years the stone have been there, but it is a slow growing disease which becomes or which is diagnosed only when we take out the gallbladder. So that is why I kept it, and I wanted the young faculty to have, because you have deep insight into gallbladder cancer. You've seen so many patients with upfront as well as incidental, which are referred to you from all over the country. And I think you brought it out very well that answer probably will lie in the genetic studies. So maybe one of the young people should take up this, that is there a genetic difference between upfront and incidental?
So sir, I think we still don't have any direct causal relationship to anything actually, not even gallstones, not even to typhoid, not into parasite. So all these are the factors which generate inflammation actually. So the inflammatory pathway is definitely there. My hunch is that this inflammatory pathway, whenever it gets triggered, causes some genetic alteration which leads to formation of this thing. So we can never have a single factor, let it be stone or lithogenic bile or any parasite or typhoid, which we can point out will this thing. It has to be, the trigger has to be in the whole pathway, inflammatory pathway, which somehow triggers the genetic alteration which causes cancer.
So that again will be proved by genetic studies.
Yes.
Taking gallbladder cancer, gallstones and normal gallbladders with no stone, no cancer, and showing whether what you are
Yes.
saying is. So is it the genetic change which is predisposing, or is it the inflammation causing genetic change which is the cause of cancer?
Yes.
Dr. Mahesh, there was one good dialogue which I liked today in your session was revision surgery is one of the best strategy for
Staging.
restaging. That is, I think, the basis of the entire thing. And beyond PET scan, I think that is the only way that we can establish
Yeah.
the staging of the disease.
So, because we have seen, I mean, we do revision surgery, but revision surgery alone has not really, it's just like doing a radical chole. That can increase outcomes only up to a standard point. But once we know it is PT2 or PT3 or node positive, it's the systemic therapy initiation after surgery which actually improves the survival by another 10-20%.
Thank you, sir. For next talk, I invite Dr. T.D. Yadav, sir. He is professor in surgical gastroenterology at PGI Chandigarh. Sir will speak on common mistakes that are committed in management of gallstone disease.
So very good afternoon, and after so many scientific discussion and studies how to try to find the etiology and what are the correlations, inflammation, stones. Though this topic when sir gave it to me, I was wondering what are the common mistakes, and that's why probably I will not have lots of data, because whatever I am going to speak maybe because of the experience of seeing patients in a PGI when they are referred to us. So, and as I said, disclaimer is also that this is all maybe I may be personally biased also at some particular point, so I will say sorry if somebody doesn't like. So going towards my what is talk assigned to me. So I think there are different levels of mistakes created by us, by our community, meaning thereby doctors, and that includes radiologist. Dr. Pankaj is here, so please forgive me. And then surgeons who see for the first time these patients, and medical gastroenterologists or interventional radiologists, again you are one of them, and then medical oncologists. So at different levels we create some mistakes, and that is the probably reason why Mahesh is saying so much variation in the outcome of incidental gallbladder cancer. That's why yesterday also sir was discussing about why outcome is so different and how to define incidental gallbladder cancer. So this is what I have collected, what we get from the different people. So you could see the marked area that there is a clear-cut evidence of the well-defined some lesion on the ultrasound. But the second line is very important, clinico-pathological correlation. So ultrasonologist give a query mass lesion, then he suggests that go and do FNAC and correlate clinico-pathologically. And as a result, we know that when you do FNAC, there may be bile spill, there may be so many things, since our residency, we are listening that resectable gallbladder cancer should not be, needles should not be put across. And that's why, so here is the first step, that there is some mistake. We are not going into details of the clinical history of the things, and the moment you see something in the gallbladder, it is tendency in most of the centers in the periphery that they advise FNAC, and immediately it is done. So people come to us with a diagnosed case of gallbladder cancer. So here first step you miss. So we go another patient. You could see that this is a patient where these are the lesions, and if you see this lesion as a sludge, and then again what to do? And people say that there is a sludge in the gallbladder, and we are finding that people go and operate these patients. So again, when there is a sludge, we request Pankaj or our friends, when Pankaj did not join PGI. So my friend will do color Doppler. Pankaj said there is no role, but he used to see, Anupam used to show that there is some sort of vascularity in the lesion, then this is probably not benign. Then we will go one step ahead and try to do CT scan based on our approach. And this is what he used to show. He showed in one of the pictures that in a sludge which is not malignant, you will not find these vessels inside it. And based on that, we used to go further. Because these are the very clear-cut lining between the liver and the gallbladder. It is probably one of the early lesions. But if you go and do a cholecystectomy, what Dr. Mahesh is saying, then outcome will be totally different, because you are not only that, you are Dr. Mahesh, you are saying, we are also disturbing the pars plane between the gallbladder and the liver, and from where all the vessels which are portal vein, the radicals which are draining the gallbladder, they go, and those are open. So these are the certain things. So I think mistakes are there, done at this level, and again, we say just to advise what to do in this type of lesion, then no to simple cholecystectomy. We should go to one step ahead and try to do some more investigation to rule out the gallbladder cancer, not to prove gallbladder cancer. It is also important that we should go to rule out that there is no gallbladder cancer, so that we are not going to do any this type of mistake which are detrimental for the outcome of the patient. So summary of the sludge in the gallbladder is a warning sign. Proper clinical history and correlation must be done, and further investigation must be done, and no to FNAC once it is a resectable gallbladder cancer. This is the traditional teaching, we are going by that. So second patient, 40 years female with pain abdomen. I just covered the name and of the doctor and the patient, and you could see in this patient also, Pankaj has told lots about thickening, so I will not repeat the same, but you could see that there is a clear cut. Contracted gallbladder with the thickening is much more dangerous. So if distended gallbladder is thickening, maybe ultrasound may be very good investigation, but once there is a contraction, in our Dr. Pankaj's talk also, the article also it is mentioned. So this is the patient who asked this patient to wait for 9 months. So patient waited for 9 months, and then again ultrasound has been done, and you could see that what has happened to the liver. So liver has developed metastasis. So here I feel that there is a mistake, whether clinician asked them to wait, or whether radiologist on its own wanted to follow, because in the earlier ultrasound he has written follow-up is not available, and the next he has written that follow-up ultrasound shows thickening. So this is again big mistake, and that's why we will just see the gallbladder wall thickening. If we are seeing, just to summarize again, focal thickening, irregular thickening more than 6 millimeter are the warning sign in a contracted gallbladder. More and more investigations should be done, and pictures from the same, so I will just skip it. And same publication what Pankaj was saying. So going more investigation, you could see on the CT scan here, plane between the fundus and the liver is gone. So this is a clear-cut case of gallbladder cancer, which might be early. So by doing any type of intervention, by doing cholecystectomy, we are disturbing the plane, and we do some mistake, which is again very detrimental. Our data which has been published, that it has shown that if there is this is about symmetrical circumferential thickening, it's not about focal. And we have found if thickening is more than 6.5 and goes to more than 1 centimeter, then chances of gallbladder is much more high. So we could see that specificity and sensitivity goes in the tune of 94% once there is a cutoff, crosses the cutoff value of 7.5. So it is also very important. Even if there is nothing, no other features, if this thickening is there, circumferential thickening is there, then we must try to investigate more. This particular slide I will skip. So I am going 2-3 very eye-opening cases. You could see that known case of gallstone disease for last 1.5 years, and the recent history of pain abdomen for 2 months back. Ultrasound suggested thickened query mass. This was written on the ultrasound. Then it was CT scan was done, again confirmed the same thing. In spite of that, these are the reports. Just to say that ultrasound suggested mass lesion, CT scan was done, suggested mass lesion. After that, underwent about 2.5 centimeter incision, mini cholecystectomy. Surgery duration has been written 1 hour, intra-blood transfusion was not done, and patient was kept, drain was kept. So we send a question, if get a phone call, was there a bile spill? Answer was no. Was there a stone spill? Answer was no, because very educated patient. So biopsy suggested adenocarcinoma, P T2, N0, MX was not. So this patient was such a disease was so this thing. So was there biopsy? This was the question we asked for the proper information. And this patient, again, we did it, staging lab, staging, just to show that what all this patient required. And this was, cholecystectomy was done alone. Then again, extended cholecystectomy with resection of the duodenum and distal stomach was done. And these things were required just to, and a CBD excision. So all those things were required. It means that here is the mistake. In spite of CT scan, in spite of ultrasound, you are going ahead. Who is responsible? We don't know. But these are the mistakes committed. Another patient, again, same patient, another patient, this patient has right upper abdominal pain for 6 months. There was no history of jaundice, but there was a history of, as I was suggesting yesterday, history of loss of appetite and weight was present. CT scan showed there is a chance of thickening, and there may be a Murgy syndrome was suggested on the CT scan. And in spite of that, this is the report of the CT. I will not show, but only thing is that in spite of that, laparoscopic cholecystectomy of the gallbladder was done. And the patient was referred to us by the medical gastroenterology because there is a biliary stricture which was not amenable for the endoscopic management. So we found there was a ascites. Then what we did, we tried to aspirate the ascites, and there was a malignant cells. Then we asked for the block, and block was available. It suggested adenocarcinoma. So these are the big mistake that in spite of all the investigation you are doing, you are going by the laparoscopic cholecystectomy. So I think at this level we can say that mistakes are being done deliberately or ignorantly, we don't know. But these are the different level of the mistakes, and most of the mistakes are done by us. With jaundice, yesterday also I asked our colleague, what about jaundice? So the moment surgical, there is a patient with surgical obstructive jaundice, the people think that this patient is not operable, and metallic stent. This young lady, 35 years, there is a metallic stent was put. So we did because it was a locally advanced, looking like locally advanced, for obstructive jaundice we follow very strict protocol. If more than 2 organs other than CBD is involved, we go ahead and try to do neoadjuvant therapy. Neoadjuvant therapy was given, Jamox regimen, and this was the metallic stent put, and you could see that tumor has very significantly gone down. The PET scan suggested no extra disease, and this was the extended cholecystectomy with lots of hard work. We could resect the common bile duct, and we could do the proper extended cholecystectomy with hepatic duct resection, and she is again receiving post-operative adjuvant. The point to be seen here is that even in a setting of obstructive jaundice, you could see about 11 lymph nodes, which are none of the lymph nodes are involved. So I mean to say that there are certain things which are in our gut. We decide by the historically that surgical obstructive jaundice is there. Now let us put something, and no need to go beyond that. So these are the areas where we have. For the obstructive jaundice, I have to summarize that all CAGB cases with SOG are not irresectable or not metastatic, and we need to have a proper evaluation. At least about 10 to 15% of the patient are being resected. So we have to do justice with them. Obviously, NSCT, neoadjuvant chemotherapy is our every time we try to use it. Whether bag was used to remove the gallbladder. Yesterday there was a question, so again this controversy has come. So 34 years female, preoperative ultrasound, GB polyp in the fundus. Again, all these are the mistakes, collection of the mistakes. Lab cholecystectomy in 2018, HPR is not available. Mass, again another mistake. So mass with purulent discharge 2019 January on the epigastrium. So another mistake, IND was done in the local hospital and showed adenocarcinoma from the biopsy, tissue SVR. So presented to PGI-MER with non-healing ulcer. So this was the presenting picture. So yesterday I was saying that we did a PET scan, and then this was the picture after the chemotherapy. And then we went ahead and excised the port because as I said yesterday, if more than 2 years are there, usually no need to go ahead. And she is correctly doing well. I don't know, is she going to survive long? But see the duration between the first surgery is more than 2 years. Almost more than 2 to 3 years. It means that this tumor is particularly slow growing, and this tumor is also Bag has not been used, that I repeatedly say. So I think these are small, small points teach us a lot. And based on this, we make our opinion. So as I said, this particular paper is being quoted by every, our society that we should not be using bag and all. I don't know because I don't have any so-called objective evidence to suggest that. Then cholecystectomy and sending frozen. If there is a doubt, there are 3 types of doubt in a gallbladder cancer on radiology. Very high suspicion, there is no doubt that we go and do on the cost of doing little bit of extra, we do a extended cholecystectomy. Another is very low, we try to do some other things. In between is there, where Dr. Kapoor sir described antiseptic cholecystectomy, you also follow that. Little bit of wedge of the liver is taken. By the simple fact that if you see the gallbladder, this is the way, this is from the Japanese study, I have just drawn this area. The way blood is drained in the liver bed. So if you work here and do a cholecystectomy, send for the frozen, the purpose of the oncology is defeated. So this is another mistake people do. Still we are doing in front of our eyes, it is being done. So this is another mistake we people do. We should do proper 1 centimeter, 2 centimeter wedge resection so that we are not disturbing the plane, send for frozen, if it comes positive, go ahead. I was seeing one video in a conference, and person is seeing 3-port cholecystectomy and he is taking a suture, and suture is thin wall gallbladder going inside the gallbladder. So when sir said me that thing also crossed my mind, that why for 1 5 mm port we try to take the suture and spill the bile. This person unfortunately comes to be adenocarcinoma, then it is going to have a bad outcome. We know that, literature suggests that. So this is another big mistake we create. And missed gallbladder cancer, as I was suggesting, this is our data. And then routine biopsy or no biopsy. So this is a very quoted data by the 2 centers, UK and Sweden. We know that how much is their incidence of gallbladder cancer, sir was telling. So I think we should not take everything from this data, and we must say we do not do this mistake of not sending patient, and we must do histopathology from an appropriate good center. So I think I have no other thing to say that what are the all mistakes which being done. There are many things are being done, like not defining genetic history, most of the things, and we are not able to define which patient will require preoperative chemotherapy properly, other than radiology, which patient is going to respond to which particular chemotherapy. But these are the essential mistakes which are done at a basic level. And if I improve all these basic level, many of our gallbladder incidental, so-called incidental gallbladder cancer would not be there. So to conclude, at this particular level, as I said, we have witnessed mistakes at multiple levels. Most challenging is the wall thickening. Sometimes it's ignorance, sometimes rest of the time it's hunger, professional hunger or other hungers. It's a matter of ethics and surgical principles we have to follow, and nobody can teach that. At the end, we have to realize that our aim is primum non nocere. So first there should not be any harm. And I convey my sincere gratitude to all my friends and SR and obviously our patient who give us all this wisdom. I thank you and convey my regards from PGI Chandigarh.
TT, this was not an original question. It came as an afterthought to me, so that is why there is no group created for this. But after listening to you, I feel a very important and very good message can go to the general surgical community. So I would request one of the younger faculty members to help you in doing this, a small write-up, that if you are dealing, as a general surgeon, if you are dealing with a gallstone disease patient, what all precautions you need to take. And it could easily be published in either Amasi Journal or Indian Journal of Surgery, which has a wide reach amongst the general surgical friends.
Thank you, sir. I was also thinking, when you asked me to do that, then I started realizing and collecting over this thing. So we can do that. I will take Kailash and do this. Yes, sir.
Yeah, couple of things, there have been a spate of papers recently which suggest that we can do away with routine histology of the gallbladder. For this specific forum, I think that must be a strong recommendation that we should not be avoiding it. In fact, what all we should be looking at in pathology, that's one. Second is, I think the commonest I've seen where you have either missed strictures or late, this thing is a history of pre-op jaundice. especially if it is trivial or not taken properly, or abnormal LFTs before surgery. And I've seen that for the last 30 years here, UK, everywhere. It's a very recurrent motif that where, especially in our setup. So you've been in areas where it's a high density, but high. You immediately think of CAGB, but wherever it's not a high, it's actually more important where it's not, people don't think about it. So I think having a look at all previous LFTs and any abnormalities, we should have that thought in mind, that, so that we take care of this thing. And documentation of spill and all that, because I think like Professor Kapoor asked yesterday, hand on heart, how many of you actually do it? Every single time I'm not sure I've actually documented my own. So I think that's one thing, is we must write the OP notes right away. Even after writing that, and if you have a format, if you have a digital format, please put in a gallbladder format, please put a thing, was there a spill? And it's not just at that time, while removing at the port of exit. That is the time when it's, and that is not documented. Oh, I didn't cause a spill. So the whole feeling is they take responsibility for the hook causing a cut, but not there.
I think this point is very important. I was discussing with Ajay. I send letter. This patient also we send a written letter, because patient is highly educated, known to some IS officer. This lady, one of the attack. I send a written letter that can you please tell me whether bile spill occurred, whether gallbladder stone spill occurred, all those things. That he very clearly said no, nothing has occurred. The only one person in whole one person we have, he's a person practicing surgeon in Bijnor. Probably we operated one incidental gallbladder cancer operated by him, and we sent these messages. So next time he operated one incidental gallbladder cancer, the patient comes with the discharge of another person, and a note mentions on another paper, there was a stone spill, there was a bile spill, and gallbladder was taken in pieces. He writes this, and I have that preserved that note that he wrote, and that patient was presented in ISG. Said Dr. Harjit presented that with the HPD, but unfortunately because of all those things, this patient did not survive more than one year. So this as sir is saying, if we are pushing more to the people who are operating in periphery, so then probably this message can go, that people will try to send all these things.
And finally, the path gross examination actually will give us a clue, especially if the surgeon didn't cut open the specimen. Most of us, we say it in podiums, but we almost never do it ourselves. We palpate through the wall and probably don't do it. But if we haven't done it, or if there's an accidental spill, then we cut the same one very ostensibly to inspect it inside. But if it's not been done, we can actually see the pathologist usually very assiduously writes down, documents that the gross specimen is completely intact.
So, based on my experience as a pathologist, I would like to add one comment here. In fact, I would like to admit the mistakes of pathologists, and I would like to be included in the group of people who are making mistakes. I will accept this mistake.
Yes.
We need to, first of all, we need to change the attitude of the people, attitude of the surgeons, whosoever is doing the surgery, whosoever is doing the cholecystectomy. We need to change his attitude. Then we need to change the attitude of pathologists, whosoever is doing the grossing, taking samples from the gallbladder and then reporting the gallbladder. We all need to change, we need to change the attitude. Then we need to change the attitude of patients who are thinking that the disease is out. They don't bother to take the reports then. So we need to change attitude at all the three levels. Maybe a little more care at the pre-op level, maybe one or more few investigations will make a difference for the patient. And then at the intra-op level, maybe a little more care at the intra-op level if a surgeon opens the gallbladder and then just sees what's wrong there, what pathology is there. And then marking the cystic duct or whatever is the resection margin. Maybe sometimes there is subtotal cholecystectomy. Then at the post-op level, then at the pathologist's level. First of all, grossing. The attitude again matters. Whosoever is doing grossing, taking samples, he needs to be aware that he or she may be dealing with a carcinoma. Then the person who is reporting. I think this attitude needs to be changed. and then only we can sieve out, we can first remove the suspected and missed gallbladder carcinomas, and only then we can sieve out incidental gallbladder carcinomas, and then only we can study them, because they actually could be a different group. And what we are seeing in our routine practice, they are a combination of missed as well as unsuspected gallbladder carcinomas, and then the obviously the incidental gallbladder carcinomas.
No, I think she makes a very good
Very-
point about the pathologist being a potential mistake point, because I've seen, particularly for gallbladders, it's taken very casually, because the, especially in busy centers where onco load is high, and they have multiple specimens to take in other things, the gallbladder is not really looked at. So I think that's a very good point. The grossing must, and you can see, I found the radiologists and pathologists being the most systematic about reporting, much more than, much better than we are. But still, it's happened. Our first, no, so even in places where it's done by the, when I did my first esophagus last year, and it was a post-neoadjuvant which was documented on the pathology form, and I got a report saying that there were no lymph nodes identified. Now, this is a pathologist who is fantastic. He gives us reports within 2 days. So I went back, looked at the specimen, and took out 15 nodes. I still remember, I've preserved, he's so mortified, he says, thank you, I'm never going to make this mistake again. But just to document that, he presumed that because it's neoadjuvant, all the publications say that you get less nodal yield. So he had been careless in that particular instance.
And
So
some
I
of-
think very,
one
very
of-
well point,
one
well.
of them
well
might have been positive, and there might have been some tumor deposit as well within the
Fortunately, they were all negative, but it was good to know that this feeling that neoadjuvant always, sometimes it could be that that change in the pathologist as well.
This again pertains to biopsy. Whenever somebody utters a word of cancer, the patient will directly go to the oncologist, and first thing they'll do is they'll ask for a biopsy. There are clinics of interventional radiologists. Patient goes there and biopsy is done.
So, that's why I told you that there are multiple level mistakes. So medical oncologist, if they go, they will. That's why I was not very emphatically mentioning that, because that particular data was evidence was not there in my hand. But the question is, if they go there, especially after incidental, they immediately go, even it is resectable, something like that, we are finding they take some sort of chemo and they come back. Many of them might not respond to chemo. But that point is very well taken. The question is, pathologist or anybody, that's why I don't remember her name, she pointed out very nicely, because at multiple level, attitude change is not something which can be done very easily. Let's be very fair in that. So many years everybody is talking in CME, and is still incidental gallbladder cancer. All these things are recent reports. So it is coming like this only. So people know, still they go ahead. That is what I can say. That, but message should be that it should be, as sir said, we can make a write-up. You can go to this type of talks, little bit more in more gathering. That may be the another way of looking at it.
Last question, I just want to point out one more path issue is specific to gallbladder is, since the patient gets discharged early, we need to have a mechanism to make sure, you did allude to that, to collect, because I have had at least a couple of times that I have not, so this is specific for government hospitals where there's a large load and there's no information is not passed, or where the biopsy is done at a different center from your own. So, like in smaller nursing homes and all, where they send it outside. So that we need to address that mechanism of ensuring that we get a biopsy back.
In our department, we had made a system. Every Tuesday morning, they will report all the last week's or the pending biopsies. They will have a register with biopsy has been sent and not been reported. So every Tuesday, so we can make some method.
I just had a word, sir. I work in a department which is newly formed, so I had that liberty to start something which I could do as per my wish. So one thing is that I do not allow my patients to collect biopsy from the pathology department. My resident goes every week and collects the prepared reports, and we deliver them on the OPD days. When they come for follow-up, we give them, so that we have a complete data of what we are giving them back.
After reading it, hopefully.
After reading, yes, definitely, and documenting it. We are making a separate HPR file for in our department. Second thing is that we added, though we are not very successful, but we hope that that will work out well. We added this Aadhaar card number to the discharge. So we have now a better tracking system of the patients. Though we are not able to implement it fully, but at least we have a tracking number of the patient. Thank you.
Thank you.
it's related to pathology and grossing only. I seen we are making a recommendation that surgeon should open the gallbladder and see, but I am really not for it actually. Our pathologists tell us not to touch the gallbladder. They will cut gross themselves to look at cystic duct margin, and their way of grossing is totally different than a surgeon shredding the gallbladder open for them, which they don't like. And other point of this thing, if you don't have a frozen section, what are you going to achieve by opening the gallbladder on table? Are you going to change your decision of surgery based on a polyp which is seen, which may be a malignancy or no? If you are not going to change anything in your surgery, why do you want to open the gallbladder only and see?
Dr. Mahesh, this was actually regarding the opening of gallbladder. This was discussed day before yesterday when pathologist was presenting here, that how to open, it has to be longitudinal, it has,
Yes.
you have to mark the cystic duct and all. So, and plus I think opening is always important. If you have found something on table there itself, send it for frozen. We have had this, that.
I'm saying, it's
Yeah.
if you have no facility of frozen and examination at that some point of time, then why are you opening only?
Sir, then at least once you open, if you find some lesion, you will be more keen to know the biopsy
Careful.
and at least refer it to the
You
right.
change your decision on table of surgery. If you
We
are
change
not,
it on
then
table. We change it on table.
So I,
usual thing you are not going to change your decision.
Dr. Mahesh, I will just narrate one story. When I joined in 99, because of the Sanjay Gandhi, this thing, I had one gallbladder, and which I was told by the pathologist within 7 days that this is a malignancy. So I and my SR went to the address. That time there was no mobile, and we went to that area in the village, and we caught hold of that lady, and we brought her back, and we operated. So it's all what she suggested that.
So, PD and
Yes, sir.
Kailash, in this write-up,
Yes, sir.
we have to be very blunt. We have to say, do this, do not do this.
Okay, sir.
Every step, whether we offend a radiologist, a surgeon, a medical oncologist or gastroenterologist, doesn't matter. We have to be very blunt that these are our recommendations. And I would go a step further. I have been thinking, but I don't know how to do it. We need to go to the people. We need to tell the patients that if you are being operated for gallstone, ask your surgeon to send the gallbladder for histology and tell him or her that whatever the report comes, even if I don't come to you for follow-up, you have to send me the report. And my effort is that incidental gallbladder cancer should be made a reportable disease. So a pathologist sees it, she has to call the surgeon and tell that, look, it is an incidental gallbladder cancer. And then the surgeon has to call the patient and tell that, look, you are found to have an incidental gallbladder cancer. That is my effort, that it should become a legislated thing, like other reportable diseases.
Thank you, sir.
Sir, if not opening of the gallbladder intraoperatively, but I would insist on making the resection margin visible, like marking that resection margin, because sometimes the gallbladder is so much distorted, we are not able to see the resection margin. Once it has been, once sampling has been done, when we re-look the gallbladder, it's not possible. If it's the carcinoma, then it's not possible to take the resection margin that time. It's so much distorted, and sometimes it's the mucosa is obliterated, and it's not possible to take that time. Yes, cystic duct is, yes sir, cystic or the resection margin.
Yes, please.
So thank you, Teddy sir.
Thank
You have nicely explained the common mistakes with the real case scenarios. So now we move to next session, and this is on current recommendations for management of incidental GBC. Dr. Sadiq Sikora will present this talk, and he is ex-professor in GI surgery, SGPGI Lucknow, and now he is HOD in GI surgery, Sikora Hospital, Bangalore. Over to you, sir. So he will be summarizing the whole 3 days sessions we discussed in last 3 days.
Those who want to record the consensus of last 2 days, you can record just now.
So good afternoon, and first and foremost, I mean, I think I applaud your effort to get everyone together and be persistent with the problem and find solutions for that. And we have been your foot soldiers and would continue to do that for you because the effort is tremendous. So thank you very much. So what I'm trying to do is going to go through what has been talked about in the last 2 days, and I have basically will concentrate only on the incidental gallbladder cancer and not the other topics which had fared in this. And these 7 questions were what cropped up in the discussion, and this is what we'll address one by one. I will request Puneet, if he's concentrating, can you note down if something else comes up, or Ajay, can you do that?
I'm recording it.
Okay. So the first was the definition of gallbladder cancer, incidental gallbladder cancer. And there was a lot of discussion, debate, and at the end, what transpired was gallbladder cancer reported in histopathology following a cholecystectomy with no evident preoperative suspicion. And there was a lot of discussion on this. But we have to accept that there was no evident preoperative suspicion on clinical evaluation, imaging, and even at surgery. And I know there are a lot of things about missed, suspicious, all that. But when it is first diagnosed on histology, and we don't have access to all that, we will continue to accept this as incidental gallbladder cancer. Of course, this is subject to a complete histopathological examination provided, because otherwise it will come as missed and follow-up. There was a question about where we should put this, and is it a different disease altogether? That if you detect on the operating table, is it different from incidental gallbladder cancer? And we didn't come to any conclusion, so I've just put this, that I wonder whether this is any different than what is being picked up on histology if you don't examine there. And the outcome is whether it is different or not. So for this purpose, for purposes of this, the first 3 lines would define incidental gallbladder cancer. Just to show that low incidence countries and high incidence countries, the incidental and truly incidental figures are quite different. And that is what we are emphasizing all along, that there are different incidence of these cancers, even in incidental and truly incidental. And the NCRP data, which Dr. Prashant Mathur spoke, matches this high incidence countries, because he said about 8% the unpublished data. Why it is important again is to know histopathological examination of GB specimens. And I think there is no doubt, this I'm quoting from the meta-analysis, that most high incidence countries did histopathological examination in all patients. And this came out in 83% of studies. Whereas in non-endemic areas, people were more selective in how to examine this or send for examination. So we are clear that we are in high endemic region, and we need to send all specimens of gallbladder for pathologic examination. But I found this very interesting, and I think this is one area which we need to work on. So this is a Dutch tool, and this, again, this was the one on the right side is the American study. Both have looked at some clinical features which would indicate a high risk of incidental gallbladder cancer found in these patients. And I think what we need to do is, we all have so much data, and what we need to look at is what clinical factors are related to incidental gallbladder cancer in our setup, and we need to develop a scoring system for that. And we may include the GB RADs in this if we wish, so that we have a comprehensive clinical and initial imaging tool which will tell us that this is a high risk for a incidental gallbladder cancer, and then we take steps accordingly. I'll come to it a little bit later. Now, this is an algorithm, you may not be able to see it, and this algorithm was suggested in low endemic countries from the Dutch group to say that when to send for pathology. But my reading of this is we should use it to ensure that a detailed pathological examination is done of the specimens. So if there is a morphological issue which on imaging, on gross morphology, on these clinical features, these are the specimens should not be treated as usual specimens. They should undergo a detailed examination. So as I said, they said these should be sent for pathological examination. I would put it that we could use this criteria that these should be extensively evaluated and examined as a complete, we talked that day about 6 sessions, 3 plus 6 sections, or a complete evaluation of 85% of gallbladder. This needs to be decided. We kept on, had a session on information which is required, operatively on pathology, a wonderful session, and most of it is very clear that what approach, lap, open or converted, whether there was any GB focal thickening or mass appreciated during surgery, whether there was perforation, bile spillage, was it a total or a subtotal cholecystectomy, whether there was adhesion to adjacent structures, extraction of the gallbladder in bag and the port of extraction, and whether there are any suspected findings which the surgeon did not pay attention and in retrospect now feels that it is important. Now we all know this, the problem is how to ensure that this is reported, and as Dr. Kapoor mentioned in that session, so we need to develop a template for recording this operation notes and information, and once we have that we can circulate or make it mandatory that everyone keeps records in this format, and these records are submitted in case they are referred subsequently. Histopathology, we have had a wonderful discussion, and of course these are the things we are going to look at: size, location, cystic duct margin, and whether there is any lymph node in the specimen, and in microscopy the T stage, the histology, grade, PNI, LVI, lymph node positivity, margin status, both cystic duct and liver. And we've just heard the comment which was very sharp and incisive, which said that we need to ensure that all these things are looked at and also reported. And we need to also give them a sort of idea that in which cases you should look all this very thoroughly. So if you have some indicator for IGBC, then we can request them. And again, in this also, we need to develop a template by the pathologist that they would include each and everything when they are reporting so that nothing is missed out. Now we talked a lot about predictors in this and what to do. So this chart came out consistently that pathological examination will give an idea in an incidental gallbladder cancer that what is the risk of residual disease. So this included T stage, grade, LVI, PNI, and we know that these are all important markers or prognostic markers or outcome. Of course, this missed the lymph node status and the margin status, which should also be there in case there is a lymph node, and if the margin is there, this also needs to be mentioned. So based on this, one could have this low risk and high risk disease and intermediate, and we know that based on this, data is quite clear that with high risk predictors, the residual disease is very high, and this should be used consistently to when you are reporting to say whether it is intermediate, just like we do in GIST. we give a risk assessment of that. And for an incidental GBC, we should give a risk score for this, which is primarily pathological. So we should give this, which gives an idea for subsequent management that whether you're going to go in for surgery or a new adjuvant and so on and so forth. We had big discussion on staging prior to resurgery. So more or less it was agreed that once the patient comes to you having had a cholecystectomy and a diagnosis of incidental gallbladder cancer, you need to undertake few evaluation steps in those. So you need to review pathology slides and block if those are available. You need to do some tumor markers, and CA19-9, CA125, these are there to do. There was a lot of debate regarding what is the best investigation to do a restage or staging at that point of time, and various opinions came forth. We, I think, came to a little bit of consensus regarding the fact that we should do a contrast CT plus PET CT if cost is not a consideration, and based on the T stage. If it is early T stage, maybe a contrast CT may be enough. Or we also had a lot of discussion on whether MRI is better in this scenario than a CT scan. The final vote didn't come on any of these. So we could have options of this as a restaging, but I think the critical factor is what PT stage is reported on that incidental gallbladder, which will tell us to what extent we should do the staging in this patient. As I said, that there was a lot of discussion on false positive, but what we agreed upon is that at least a distant disease, if it is present, especially in high PT stage, you would be able to document that, and it would change the management. Timing of surgery, we thought that there would be a whole lot of discussion, but the data was not enough. We knew that there was no definite consensus. There was no consensus regarding what is early, intermediate, and late in literature. But whatever came out of it, it was intermediate, which seemed to be the best time. But the most people felt that resurgery, if indicated based on all other parameters which we have discussed as far as regards the histology, if it is indicated, should be offered to all patients irrespective of the time of presentation, because there is no consensus on that. So whenever the patient comes, whether in the first week, second week, third week, or whatever, we do know that there is a period of time where the outcome is best in terms of the survival, but I think that resonates from the fact that you have weeded out the patients who had extensive disease or disseminated disease by that point of time, and therefore it reflected in the survival. The treatment sequencing was another major area, what to do. So PT1A disease on a good pathological examination, being absolutely sure that you are not missing the T1B. If that is the case, then cholecystectomy is enough. We all agree upon that, an observation. PT1B was a matter of debate. A lot of data was shown. Murugan showed us a lot of data, and it said that there is enough data which also said that simple cholecystectomy as good as extended cholecystectomy, but most people would agree to the fact that in PT1B, for a better complete staging, resurgery and extended cholecystectomy may be the best way to go. But it's subject to review in each patient and each surgeon who encounters that, provided they consider all the factors. Now conventionally PT2, when we encounter, and of course after staging when it is still localized, resurgery and extended cholecystectomy is the recommendation, and that is what most people agreed. PT3 also, whenever the patient comes, if there is no evidence of disease, metastatic, then resurgery. And if on resurgery there is residual disease detected, then one should offer these patients adjuvant chemotherapy. So these are the standard parameters which have been propagated, which were accepted, and most people showed data for this. But there is a new area of approach to these patients of neoadjuvant chemotherapy, which was highlighted both by Rajiv Gandhi and Tata Memorial. And there were certain groups of patients which needed consideration for this. So those were bile spill in any T stage. One came to the, or at least there was discussion that these may be the group of patients wherein at least wait and watch, and while waiting and watching, you may offer them neoadjuvant chemotherapy. We talked about the high risk predictive histological factors. Those with high risk could be candidates for a neoadjuvant therapy because we know that residual disease possibility is high in them. And advanced T stage and node disease with significant residual disease documented on imaging, one could consider neoadjuvant therapy in this. So these are not established options, but a lot of people are exercising these options, and we need to be aware of that. What to do at resurgery? We had this talk on staging laparoscopy, so it is very clear that all these patients should be subjected to staging laparoscopy. The point which came out is it should not be just putting the scope, it should be a multi-port examination and a thorough examination of the hidden areas which Dr. Shivendra mentioned. It remains that para-aortic lymph node sampling should be done because it has a bearing on how you go about it. There have been a lot of debate on what to do if it is positive, but in general that needs to be done. As regards completion to extended cholecystectomy, P2, T2 and beyond, liver resection is beneficial, that is well known. There is some debate on PT2A, whether it does require a liver resection, but the final word is not said on that. So if you reoperate, a liver resection has to be done. And how much liver, there was a lot of debate on that, and we don't have any consensus, but all available data suggests that irrespective of what kind of resection, as long as there is R0 resection, it is good enough. Lymphadenectomy has to be complete, so complete hepatoduodenal lymphadenectomy up to the celiac axis, and also superior pancreaticoduodenal lymph nodes need to be taken off. It's now well established and accepted that for a complete lymphadenectomy per se, it should be 6 lymph nodes at least, and we heard the opinion that numbers should not be important. We should also document which lymph nodes are involved. If cystic duct margin is positive, we know that this needs a bile duct resection. There was a good talk on minimal invasive surgery. So we've come to this statement that studies are limited with heterogeneous data. It is feasible and is shown to be non-inferior on oncological outcomes and some benefit on short-term outcomes. Now the caveats for this are experience, expertise, to be beyond the learning curve, and it should follow all the principles of open cholecystectomy, which is sampling the lymph node and undertaking the resection as you would in an open. Port site metastasis generated a lot of discussion, and most people agreed that isolated port site metastasis is a different ballgame than as part of the disseminated disease. So we need to evaluate these patients, that's for sure, that they need to have a PET CT scan in order to see what, is it isolated, really isolated. And then another issue came about that the lead time between index cholecystectomy and diagnosis, is it early or it is a late presentation? Because apparently both have different connotations, especially if there is no disseminated disease. So most data suggested that port site, routine excision of all port sites is not associated with decreased recurrence or survival, but there was also a point of view that full thickness excision of port of extraction may be an option as a part of being aggressive to prevent port side, or whether you are able to prevent or not, but at least make an effort to prevent port side metastasis. So as I said, isolated port side early presentation, there may be a role for neoadjuvant therapy after complete staging, and then reviewing that and doing an excision. Late presentation, there is an option upfront, then resection, or resection followed by post-operative chemotherapy. And one option suggested was, if there is a patient is not willing for resurgery, or you don't want to do a resurgery, then a local brachytherapy with iodine may be an option. So these are all options. Not much data is available on this, and these are based on opinion. Now a couple of points which I want to highlight, that and these were addressed, and actually one speaker said that would it be wise to put this in the recommendations? And my take, how I look at it is, there are modifiable factors, there are non-modifiable factors. The pathology is non-modifiable, but what is modifiable is the way you conduct the surgery in all, because this is supposed to be in where there is incidental gallbladder cancer. But it would help if we talked about that if you have predictors of IGBC, then more meticulous care would be taken in this. So minimize the risk of bile spill. Nobody wants to do. A survey was done by Dr. Kapoor's group here, Piyush Varshney, when he was there, and they did a survey, and they found that 86% of surgeons reported that they had bile leak in patients during cholecystectomy or IGBC. About extraction of specimen, we have talked about, and whatever it is worth, it is always good to extract all specimens through with a endo bag. Send all GB specimens for HPE, and what was heartening to note in that survey was only 4.5% did not send the specimens for pathology. So I think most are attuned to the fact, or at least those who were surveyed, to send it for pathology. And as we discussed, if you are sending, mark the cystic duct for that, and then check the report, because the job is not done by just sending it for pathology, but you need to follow it up. Now, this is something which I want to raise, that when you get in the operating theater a histology which says it's adenocarcinoma, and you'd see, take two scenarios, because 88% of scenarios were when in the survey, when it was done by a general surgeon, and they referred, once it was diagnosed IGBC, to another facility. So that means it is at a facility where they are not going to do an extended cholecystectomy. So what is the recommendation to them? Do not proceed with further treatment. Document all the details of surgery as per the template prepared. Refer patient to a tertiary level facility with report, HPE slides and block, and counsel the patient and family regarding the findings and the need, why they need to go to a referral facility. I think if we get this message across with all the other points which we talked about, that what they need to do if they get or see an abnormal specimen, we won't go into the discussion of open, we have had enough on that, whether to open or not. Now the second question is, at the facility with expertise, and you have found that on frozen it is. And most people would say that's the best time to go in and do a extended cholecystectomy in these patients. I just want to raise this thing that you need to be caution, you need to exercise caution in this, that how good is the pathology reporting in a frozen section scenario. When we see high sensitivity and specificity of this, it is in very select centers, and that doesn't go all across the board. And you may have a wide range of sensitivity and specificity on frozen section ranging from 50 to 100%. Also the diagnosis vis-a-vis whether it is what PT stage it is may be difficult on frozen section. So you need to consider this at that time. The second important, a lot of speakers, Dr. Gamblin, many other speakers raised this issue about consent. Now, we presume that consent with the family at that point is good enough. But I'm not so sure. As a matter of fact, we have a Supreme Court judgment which has come a couple of years back, which said that additional procedures should not be undertaken without the informed consent of patients unless it is life-saving undertaking. So we need to keep this in mind. I mean, you're doing it for the best of the patient, we understand that. But these issues need to be remembered. Because at the end of the day, we don't have enough data to say that absolutely at that time to do it, vis-a-vis a revisit early enough is making an impact on survival or outcome in a negative manner. So we need to be aware of that in such situations. So I wanted to raise that. So the research questions which come out of all this, as far as I could go, is first, I think it's the need of the hour to have a scoring system of clinical and perhaps radiological to be on a good or a firm footing for us to anticipate that this could be an incidental GBC, so that you can consent and counsel. So it takes away that if it is in a good place, you know that you've already sounded them and you can go ahead with an extended cholecystectomy. These parameters will help the surgeon to be meticulous and or may not undertake this and refer these patients to another center. So I think this is a need of the hour as far as I see. The extent of liver resection, we have had debate. We could do a prospective multi-center study to look at in pathology how much is the depth of infiltration and correlate with PT and also at the location. So this could be another research question. A lot of people are looking at PET CT, and one could look more larger numbers and look at timing, correlate with PT and the histology. So that's is going on, and we'll look forward to that, and more people should do that as far as the research method is concerned. And the final thing is about neoadjuvant chemotherapy, because we know that it is the systemic therapy which is going to deal with the micrometastasis and the sequencing in neoadjuvant, and we should have a trial of standard treatment versus NACT in the high-risk group of predicted risk factors. And that could tell us that what is the way forward in these situations. Thank you very much, and I hope if anything is missed, it could be pointed out and we could add it to this summary. The plan, finally, the last thing, what the plan is that this presentation I will send to Dr. Kapoor, he will share with all, and maybe you will have to comment on it and make sure that all things are included, and it should be deadline based. Then we may be able to generate a report which could be a consensus statement based on these deliberations, and issues which have severe differences of opinion, we may have to do a Delphi consensus on that. Thank you very much.
Yeah, sir. The one point which is actually missing is tumor marker CA99 in the staging.
I've put that.
Okay.
Yeah. I put that. So that's what
Second,
In the suggestion of NACT
no,
suggestion for
in the workup.
in the suggestion for post, the high risk group, higher tumor markers, yeah.
in a PET scan, lymph positive disease, you consider metastatic now, or?
So see, I think we don't have enough this thing. I've written that you have to document with histology in case you are going for a new adjuvant protocol. But if you choose to resect and plan that, because there's no standard guidelines about that. So you need to, but if you have that, you could always correlate with post-operative histology. But if, like Tata Group wants to do new adjuvant in that, I feel it needs to be documented by histology, rather than presuming that it is positive, especially in early this thing. I mean, you can
I think as an
include,
exploratory thing, we should put
you
all
can
three,
include all, I mean, I have no problem with that, but these are, you need to do tumor markers, because I think in our discussion, we missed this at some point of time in the discussion, it never came up.
As a surgeon, we see patients with acute cholecystitis with suspected gallbladder cancer. So, how do you plan to include acute inflammation with the IGBC query? How to manage these kind of patients for any?
You mean you already know that there is a gallbladder cancer and it is
suspected,
presented? Yeah, suspected and is presented as acute cholecystitis. The experts here would say Ajay. I'll give my opinion at the end.
Yeah.
But these people are dealing day in and out. Dr. Yadav.
So this was discussed on day 1, that any patient with a uniform gallbladder wall thickness, and if you have a suspicion of malignancy, then get it complete evaluation. There is no evidence of dissemination. Go for an anticipatory extended cholecystectomy. Second thing is, for an acute cholecystitis, if you are doing a cholecystectomy, ensure that your suspicion is not based on the serosal deposits on the gallbladder wall. Third thing is, you have to ensure that there is no bile spill, because there is a very high risk of bile spill in acute cholecystitis.
So just a minute, from what I understand, you are saying that it is acute cholecystitis. On evaluation, it is suspected acute cholecystitis, and what should be the intraoperative approach? So you say AEC. No, it's acute cholecystitis with suspicion.
Clinically,
So he's-
a patient is having severe pain, counts are
So
raised.
clinical acute cholecystitis. So can I suggest, is sort of before this? This is after at surgery. I mean, and this comes from COVID time when the thing was shut. I had a patient which from Sujoy sent me from Delhi because there were locals there. Then 2-3 more happened like that, and a lot of them you can actually do
what are you
conservative.
suggesting?
We can this may be a group where we might do initial conservatism. See the you can within a week you'll know whether the thing is shrinking, and you'll actually have better imaging features. So we don't have to rush in for that acute cholecystectomy. That patient might go away somewhere else. That
No, sir, I recently got a patient who had a perforation with acute cholecystitis,
Can we-
and he had a mass.
there you lost your window of opportunity anyway.
Yeah,
So if it's perforation, you've not. So I think the clinical situation will tell you.
If you're waiting, then it may.
No, perforation, you go ahead anyway. You're not going to change any. You're
No,
going to.
he is saying while waiting if there is a complication. So
No, if
let's
you are-
hear what
Obviously, you
the
go ahead with. Obviously, you go ahead with a sensible thing. What I'm saying is err towards conservatism rather than aggressive acute, because the difference between them is marginal.
yeah, Dr. Yadav.
Acute cholecystitis, Saurabh, I had 3 patients. So there are 2 different type of patients. One is it has developed empyema, and there is a pus, and patient is not responding to the clinical conservative management. This patient is most difficult, and up to the extent that we had to put a pigtail drainage, but we included that pigtail excision with the when we went ahead with the reoperative surgery. But there was a strong suspicion. There was a looking like a mass lesion at the neck lesion and neck area. So as it develops mucocele empyema, same sequence has happened. So these are the patient. I think we have going in that patient doing anticipatory would be also very difficult because of the bleeding would be too much in that area because of the inflammation and infection adjacent to this thing. Second group where there is only acute cholecystitis, we should try as much as to go ahead with the conservative management.
Yeah.
And once it is done, then we can go ahead and do a
Dr.
proper
Kapoor?
evaluation.
You want to comment on that?
Sir, I think the only
No. So
question which I could think is, you are having a acute cholecystitis and there is a suspicion that is it question mark malignancy. You know,
Yeah.
that is the only thing, no?
So Ajay, if we summarize by all the views, because that's my job to summarize. So we would say that if it is acute cholecystitis with suspicion, you should do a cross-sectional imaging to ensure that there is a mass, there is a focal thickening which is suspicious.
And no
So,
dissemination.
No, I'm saying focal thickening. Then I agree that both Dr. Yadav and Puneet said that if clinical situation permits, you should try to do a conservative treatment. And once the inflammation resolves, which would in about 60-65%, then you could reassess and see what is the stage. If the patient is not responding, then you have to treat as acute cholecystitis and bear the consequences of how you treat that patient. Is that all right? Dr. Kapoor, shall we close? Thank you.
So thank you all very much. And actually, this is what the meeting was intended to be. It was intended to be a closed group meeting. And as I said on the first day, that at some stage we thought, let us open it to delegates. But fortunately or unfortunately, it remained as a closed group meeting. But I think the purpose is served. The interest has been generated. My jobs were two. One was to raise questions. It is up to all the experts to provide the answers. My second job was that whosoever I know in the area of gallbladder cancer, put them together on a platform. That also, I suppose I have done. Now it is up to you to collaborate with each other. But the two documents, or maybe three, I would say, Dr. Donati is going to prepare a report. He's already taking notes, which he said we will publish in Future Oncology, which is mainly a report of the meeting. I am going to request the young faculty, if you can, one of you can prepare a small report to be published in Indian Journal to inform people that this process has started. Dr. Sadiq has volunteered, and he sat through the whole meeting, that he will prepare the working consensus document which will be targeted to the practicing general surgeon, which should be usable. So I have requested him that it should include both science and practical things which can be done by an average general surgeon working in the periphery. And the last, of course, the primary aim was to have those 25 systematic reviews on the 25 questions, which I must thank. So out of 25, I think 22, because 2 or 3 questions did not have much interest and much response. But at least 20 young faculty members who were the content contributors, they have done a very good, very extensive review of literature. And all those drafts have already been sent to the senior authors. Now in the next 1 or 2 months, we need to consolidate that. And some people have already been successful in registering it on Prospero, some were not. If it is possible to reapply, we will try to do that. And then we will have to choose the option whether we publish the entire thing into a supplement of SGO, which is the ASCO official journal. The only problem is that it is still not in the PubMed. It is a Scopus index journal, so we will have to discuss that. Or we send each article to a related journal where the target audience will be there. So with that, I would like to thank all of you, all those who are here and all those who were here for accepting the invitation. And we will have a quick group photograph and then we go for a lunch.